Hello students, today we will discuss about the anatomy of cecum. Now you know that cecum is the part of the large intestine. So today we will see that what are the important features of the cecum and what are the relations of this part of the large intestine. So when you will see the cecum, cecum is a blind or you can say the cul-de-sac. Now this cul-de-sac or the blind end of the large intestine lies below the opening of ileum. You know that ileum is going to open into the ascending colon, but when we are talking about the cecum, it lies below that opening into the colon, that is known as ileocolic junction. So the cecum lies below the ileocolic junction. Now when you will see the position of the cecum in normal anatomy, it is present in the right iliac fossa. So this is very commonly asked question in your exam, which organs present in the right side iliac fossa. So one of them is your cecum. Now it is the first part of the large intestine. As I already told you that large intestine starts from the cecum. The large intestine begins as cecum and you know that it terminates at the anus. Cecum lies above the lateral part of inguinal ligament in the right side. So when you will see the inguinal ligament, just above the right half of the inguinal ligament, you are having this organ in the right iliac fossa. So if I will have this question, write down the organs which are present in the right iliac fossa. So you are having the two answer, one is the cecum and second is appendix. Clear? Now, what are the dimensions of the cecum? So the cecum is approximately 6 centimeter wide. So this is the question that which is the widest portion of the colon? Which is the widest portion of the colon? Answer is cecum. Clear? And it is roughly around 8 centimeter long. So when you will see the large intestine, you will find that the cecum is quite broad area and it is 6 centimeters in wide. Now this is something is again important thing is that we are talking about the intraperitoneal organs. So cecum is one of the organ which is an example of intraperitoneal because it is generally completely enveloped by the peritoneum. But sometimes the peritoneum is not present on the posterior wall because of the process of zygosis, and in such conditions the cecum may become retroperitoneal organ. But the probability of the retroperitoneal is very less. So if you have both the option retro as well as intra, then you will go with the intraperitoneal, which is more common finding with the cecum. It is usually in contact with the anterior abdominal wall. So if you will see anteriorly, when we will do the surface marking in the coming slides, you will find that anteriorly it is having direct contact with the anterior abdominal wall. So what are the external features you will find? As I already told you that when you will see the cecum, cecum is the very initial part of your large intestine. And this is the large intestine which is having ascending colon, transverse colon, descending colon, sigmoid colon, rectum and anus. So now the question comes is that there are few common cardinal characteristic features of the large intestine. So these cardinal characteristic features has to be present on the cecum also, because cecum is also the part of large intestine. So what are these three important cardinal features of the large intestine? So first feature is your presence of tinea coli. Second feature is the presence of sacculation or hostrations, and the third feature is presence of appendices epiploica, or they are also known as omental epiploica. So my dear students, when you are reading the cecum or the large intestine, you have this question, how will you differentiate the small intestine from the large intestine? So these are the three features which are not seen in the small intestine. So what is tinea? Now tinea, you know that these are three ribbon-like bands, and these bands are nothing but these are the modification of your longitudinal muscle coat of your colon. Clear? Now the second part is the saculations. Now the saculations or the hostrations are seen in the large intestine because of the difference in the length of circular muscle layer and longitudinal muscle layer. So there is a series of the pouches are seen. Now here you can see the pouches. If you will see the large intestine, you will find that the large intestine is showing the pouches. And these pouches or the saculations or the bags are characteristic features of your colon. So these pouches are present because the length of tinea falls short of the length of circular muscle coat. What does it mean? That the teneas are shorter in compared to the length of your circular muscle. It is just like a corrugated pipe which you have with the basins or with your drainage lines. So that corrugated pipe which are having the saculations or hostrations or the different pouches, and that pouches are found because this band is shorter in the length as compared to the length of your wall of your colon, which is actually now having only the circular muscles. So because of the differentiation in the length of the two muscle layer, the which is shorter is the important. So answer is the longitudinal muscle layer. That means the teneas are shorter in the length. So they have to accommodate a larger tube, and that's why the tube has to become fold. So the tube will form the folds which are known as saculations. So these saculations are responsible for the characteristic puckered appearance of your large intestine. So when you will see the cecum, cecum will also show this puckering appearance, and this is your hostrations or saculations. Now when you will see the third characteristic is appendices epiploiky. What are these actually? These are pouches of the peritoneum which are filled with the fat. So these are the small bags of the visceral peritoneum which are filled with the fat, and they are attached along the tinea of large intestine. So my dear students, this has to be very clear in your mind that if I am having this question in exam, what are the characteristic feature of the large intestine, including the cecum, because we are saying that the cecum is the initial part of your large intestine. So you have this band. So these are the three bands which are known as tinea. You are having the hostrations or saculations because of the differentiation in the length of the two muscle layers, and which is shorter. Answer is the teneas are shorter as compared to the length of the circular muscle, and these pouches are known as appendices epiploiky, which are fat filled areas. Clear? Now this is what you are able to see the cut part of the colon. You are having a very enlarged view. Now in this circumference of your colon, if you will see on the outer side, you will find at three places. These are the collection of longitudinal muscle, and these are the position of tinea. And along the tinea, you will find the fat filled areas or the bags which are known as appendices epiploiky. And out of that, you are having one more feature is these saculations or hostrations or puckered appearance of your colon. So when you will see the colon, you have to understand that either we are talking about the cecum or ascending colon or transverse colon or the descending colon, always you will find these three cardinal characteristic features of the colon. Clear? Now we will talk very little about the development of the cecum. When you will see the development of the gut tube is having three parts: foregut, midgut and hindgut. Now when you will see the midgut tube, now this midgut tube is having a loop, and this loop is having a centrally placed artery. And what is the name of that artery for the midgut tube? That artery is your superior mesenteric artery. It is coming from the dorsal aorta. The artery is coming from this dorsal aorta. Now this loop is now divided into the two parts by this artery which is present in the center. Now the loop which is proximally present is known as pre-arterial loop, and the loop which is behind this is known as post-arterial loop. So now when you will have the loop of midgut, you will have a artery in the center. This artery is going to form your superior mesenteric artery, and you have the two loops, two part of the loops. Now what will happen? Now as the development will take place, the cecum and appendix develop from the cecal bud. So there is a formation of a projection, a small projection is known as cecal bud. Now cecal bud always arises from post arterial limb, or you can say from the distal limb or the caudal limb of the midgut loop. So where is the post arterial segment of the loop? This is the post arterial segment. Now this post arterial segment continue with the hindgut. Now what is the junction of hindgut? Now the junction of hindgut with midgut is the right 2/3 and left 1/3 of your transverse colon. That means this part is going to form your cecum, your appendix, your ascending colon, and your right 2/3 of transverse colon. So what will happen that here somewhere in this part you are having a small projection, and this projection is known as cecal bud. So you have the cecal bud here, the remaining portion is going to form ascending colon, your transverse colon, and then you have the junction with your hindgut, which is going to form the remaining part of the large intestine. Now this cecal bud, which always develops from the post arterial segment of this loop, is divided, or it develops in the two parts. The proximal part of the cecal bud dilates to form the cecum, and the distal part is going to form the vermiform appendix. So this is the question for your university exam, that which part or what are the development of source of your cecum and appendix. So what will happen with this bud? You will have this proximal part is going to form your cecum, and this distal part is become narrow down, which is going to form appendix. Clear? So the question is that the cecum develops from, answer is post arterial segment of midgut loop from the cecal bud. At birth, now when you will see the cecum at birth, you have the conical shape of the cecum, that will see different types of the cecums are there, and when we form appendix attached on the apex, which is not a adult finding. It is not the adult finding. That means the appendix is not attached on the apex in a adult. So this should be there in your mind. So on the basis of this development, you are having the further types of cecum. So there are four types of the cecum. One is known as conical or the fetal type. Second is the infantile type. Third is the normal adult type of the cecum. And fourth is the exaggerated type of the cecum. So how you are differentiating these four types of the cecum? So let's see this chart. Now for the development, for the shape and the site of the appendix is going to decide which type of the cecum it is. So if you will see the cecum, if you concentrate on the cecum, there are four different ways of the cecum formation. First is that the cecum is conical and the appendix is a straight tube. Second, the cecum is quadrate. That means you are having the two saccule of the cecum like this, and this is the tinea which is arising here, and here you have the appendix in this concavity of these two saccules. So this is quadrate, where the right and left part of the cecum are equivalent or equal, and the cecum and the appendix attached in the bottom of the cecum. The third is the normal adult. In this, what will happen, that the right saccule is larger than the left, which is a normal finding. So this right is become enlarged as compared to the left. So what will happen, this appendix will shift posteromedially. So this is the important thing, that the appendix is shift on the left side of your cecum, and it comes 2 centimeter below the opening of ileum, that is ileocecal junction. So what will be the picture here? That you will find that this is your cecum and here is your junction of ileum with the cecum and appendix is present here. So this will be the image of your cecum. So here the appendix is not present in the lower part, which is seen in these two varieties. And the most important thing is that you will see here that there is a distance between the opening of ileum and the appendix, which is around 2 centimeters. But if suppose this right saccule enlarges excessively, now if this right saccule enlarges excessively, then it pushes the appendix very close to the opening of ileum. So what will be the picture then? Now what will happen? You have this type of the cecum where you are having the opening of the ileum and near to that you have the appendix. So this is what is the exaggerated. So in this exaggerated, you have only the one saccule, that means we are having only the right part of the cecum, left is almost disappear and the appendix comes very close to the ileocecal junction. Clear? So when you will see these 4 types of your cecum, they are actually depend upon the differentiation in the right and left saccules of the cecum. So the growth of the cecum decide these 4 types, and the important thing which you have to understand that in 80 to 90% of the human or in adult population, you will have the normal type of the cecum, which is also known as ampullary variety. And in this type of the cecum, the right saccule is larger, the right is larger as compared to the left, but the important thing is appendix is 2 centimeter below the ileocecal junction. But if the appendix comes in very near approximity of ileocecal junction, that means it is a exaggerated variety where the left saccule is almost absent or atrophied. Clear? So these are the 4 types of the cecum which depends upon the differentiation between the right and left saccule of cecum. Now what are the peritoneal relation? Initially I already told you that cecum is intraperitoneal organ because in 90% cases it is all around covered by the peritoneum. So it is surrounded by the peritoneum. Now because it is covered by the peritoneum, and you know that it is continue with the ascending colon, and ascending colon is a retroperitoneal organ. So there is a fold of the peritoneum which is covering the posterior part of the cecum and then reflecting on the posterior wall. So that reflection is going to form a recess behind, and that is known as retrocecal recess. And this recess is important because in most of the people you are having the appendix in this recess, and that's why appendix is retrocecal in position in most of the people. So the vermiform appendix frequently lies in the retrocecal recess, and only in the 10% cases, which I already told you, you have retroperitoneal cecum. Clear? So what are the peritoneal relation? In 90% people, the peritoneal relation is intraperitoneal cecum. And because the peritoneum is covering the whole anterior posterior part of the cecum, and it then reflects from the posterior wall, and that's why there is a gap is present behind, is known as retrocecal recess. Now what are the visceral relation? So when we will see the visceral relation all around the cecum, anteriorly you are having the relation with coils of intestine and anterior abdominal wall. Now my dear friends, here you can see the anterior abdominal wall. Now what we have done in this image, that you have removed the midline area of anterior abdominal wall. We have removed the rectus sheath, we have removed the rectus abdominis. But after removing the middle portion of your anterior abdominal wall, still I am not able to see the cecum. That means the cecum is located on the right side of your anterior abdominal wall. So you have the cecum here. Now this is the area where I will find the cecum when I will remove this right side of external oblique, internal oblique transverse abdominis, and when you will go deep to the anterior abdominal wall, you will find the cecum is placed here. plus it is partially covered by these loops of small intestine. So, here in this image you can see now we have removed the side muscles. Now, I have not removed the midline structure which has been removed in this diagram, rather than we have removed the right side of the anterior abdominal wall, and now you can see, you can visualize the cecum is here. So, my dear students, this is very important to understand that cecum is present in the right iliac fossa, and anteriorly it is related with the anterior abdominal wall. Anteriorly it is related with the anterior abdominal wall. So, when you will remove the anterior abdominal wall just above the right side of inguinal ligament, you can see that there is a presence of cecum. Now, in this video you can see that if we will remove the layers of anterior abdominal wall layer by layer, now this is your anterior side of, now if you will see, if you fade this anterior wall, now the cecum is visible behind, but if you will remove, it is very clearly visible that this is the presence of cecum, and anteriorly the some part of the intestinal coils also having the relation with the cecum. Clear? So, when you are having the anterior relation, you have two things, anterior abdominal wall and some part of the intestinal coils. Now, what are the posterior relation? These are the more important, and you have the most of the time questions based on the posterior relation of the cecum. So, posterior relation of the cecum are multiple. There are muscles, you will have the arteries, you will have the nerves, and but obviously appendix, which I told you, which is present in the retrocecal recess. So, what are the muscles lies behind the cecum? Now, when you will see the cecum here, you will see that posteriorly in this right iliac fossa, you are having the muscle arises iliacus, and you know that iliacus always run with the psoas major, both of them will form the iliopsoas tendon which attached on the lesser trochanter. Now, we are saying that our cecum lies on the right iliac fossa, it is occupying the right iliac fossa. So, this right iliac fossa floor is already formed by these two muscles. This is your iliacus muscle and this is your psoas major. So, this is the first relation, muscles. So, which are the muscles? Right psoas major and right iliacus. Now, the second relation is visible here. Now, if you will see that there are two arteries which are seen in this image, these are the right and left testicular artery. Now, this right testicular artery, if you will see the pathway, now this is your superficial inguinal ring which will come here. Now, this is the superficial inguinal ring position, this will be the position of the deep inguinal ring. Now, then you can see that it is running on the posterior side of the cecum on the anterior surface of iliacus muscle, and it is, you can see here, it is a branch of your abdominal aorta. So, this artery is coming from the abdominal aorta, running on the anterior surface of the psoas, and it is then coming into the testis. So, here in this portion, it is coming in the posterior relation of your cecum. If it is a female, then you will have the ovarian arteries. So, these are the two important arteries, testicular in male and ovarian in female. Now, this has become the question of your exam. Name the nerves which are related on the posterior surface of cecum. For that, we will see this image. Now, in this image, you can see that you are having the lumbar plexus. Now, lumbar plexus is present into this portion, and you are having the branches which are coming out from the lumbar foramina. Now, from the lumbar plexus, the nerves will come out after piercing the different surfaces of psoas major, because the lumbar plexus is all around covered by the fibers of the psoas muscle. So, here my dear students, you can see there are three nerves on both the sides. Now, what are these three nerves? If you will go from medial to lateral side, there is a first nerve. Now, this is the genitofemoral nerve. Now, this genitofemoral nerve runs on the anterior surface of psoas major, and later on it will divide into the two branch, genital branch and femoral branch. The next nerve which you can see on the lateral border of the psoas major, which is a very big nerve, Now this is your femoral nerve, and this femoral nerve enters into the thigh. And the third nerve, which is more laterally placed, is the lateral nerve of the thigh, or it is also known as lateral cutaneous nerve of the thigh, which enters into the thigh by passing below the lateral end of inguinal ligament. So from medial to lateral, there are three nerves which are present on the posterior side. What are these three nerves? Genitofemoral nerve, femoral nerve, and lateral cutaneous nerve of the thigh. Now if you will place the cecum in the right iliac fossa, you will see that all these three nerves are now behind the cecum. So this is your cecum, and you can see this is the lateral cutaneous nerve, which is here, you can see posteriorly. This is your genitofemoral nerve, which is you can see in the posterior part, and this is the femoral nerve, which is emerging from the posterior side of your cecum. So this is what is very important question for your exam, that what are the three nerves related posteriorly to the cecum. Now this is what is the inside the cecum. Now if you will cut the cecum and see inside, you will find three communication. Now this is the cut section of the cecum, where you can see the three communication. This is the opening of the ileum. We have cut the anterior wall of the cecum, and you are seeing there is a opening. Now this opening is the opening of your ileum, and this is known as ileocecal junction. Now here you can see there is a small opening in the lower part, and this is the opening of appendix. This is appendicular orifice. Apart from that, this border, this is the line of demarcation. Above that you have ascending colon, and below that you have cecum. That means above the level of opening, this cecum is communicating with the ascending colon. So you can see there are three communication. One is with the appendix, second is with the ileum, and third is in upper direction with the ascending colon. And what is the line of demarcation between the cecum and ascending colon? Answer is this opening of ileum, or you can say this is the cecocolic junction. So what is the cecocolic junction? Cecocolic junction lies at the opening of ileum in the cecum. Clear? So superiorly it will continue with the ascending colon. Medially you have the ileum, and the important thing is that the opening of ileum is, or you can say the ileocecal orifice, is at the level of cecocolic junction. So this is very important question, and this junction lies at the transtubercular plane. Where? At transtubercular plane. Clear? And the third is the communication with the appendix. So first, if you will see the interior, you will have the two major orifice, ileocecal and appendicular orifice. So ileocecal orifice, again I am saying this, that it is a very important question. What is the importance of ileocecal orifice? The answer is that it is a plane, or it is a line of demarcation between the junction of ascending colon and the cecum. Now if you will tilt, and if you will tilt the body, and if you will see from the posterior side, you will find that posteromedially there are two openings. In the upper part you are having the attachment of the terminal part of the ileum, and this is the attachment of the base of appendix. Clear? So what is ileocecal junction? If you will open the cecum, if you will see inside, what are the important features of this ileocecal junction? So the first and important thing is that it is a junction of the cecum with the ascending colon and demarcated by the entrance of ileum. So this line is coming again and again, because this is very commonly asked question in your multiple choice, that at what level the cecum continue with the ascending colon. So there can be the two answer. One is the position of ileocecal junction or the opening of ileum, and second is transtubercular plane. Then you have the next point is that this opening is guarded by two valves. Now here you can see there are two horizontally placed valves. Now these valves are present horizontally. This is the upper valve and this is the lower valve, or you can say the flaps. Clear? And These walls are composed of the superior and inferior flap which are covering the opening, and at the margin of the wall these flaps will join together and their ends are known as frenula. What are they known as? Frenula. So, this is one frenula, and so this is the one side frenula and this is the another side frenula. Clear? The musculature from the ileum contains into the flap forming an sphincter. What does it mean? That if I am having a question that this ileocecal flaps are formed by muscle of cecum or muscle of ileum, answer is muscle of ileum. So, what is the function of ileocecal valve? So, first function is that it prevents the reflux from the cecum to ileum. So, they are preventing the backflow of the fluid from cecum into the ileum. Second, they are controlling the passage of contents from ileum to cecum. So, one is to control the input from ileum to cecum, and second to prevent the backflow from cecum to ileum. Now, what about the appendicular orifice? Now, see, appendix is a vestigial organ, so there is nothing very important about this orifice. But there are 2-3 important questions related to this opening. The first is that it is attached on the which part of the cecum? Answer is posteromedial wall. The second question is, what is the distance of base of the appendicular attachment from the ileocecal junction, which I told you it is normally 2 centimeters. If you will see the junction, now this is the opening. Here you can see that this is the opening of your ileum, this is the opening of your appendix. So, this distance is around 2 to 2.5 centimeter. Externally, you will find the base is attached here, which is also around 2 centimeter below. The orifice is guarded by insignificant. The significance is not there, but it looks like a valve, and this valve is known as valve of Gerlach. So, sometimes you have this question, what is the valve of Gerlach? So, it is nothing but it is a falsely placed mucosal fold on the appendicular orifice. Now, the point of the attachment of appendix to the cecum is consistent. That means the important thing is that what is the importance of this word consistent? Because when we are talking about the tinea and intraoperatively a surgeon has to trace the appendix, which may have the variable position in terms of its tip. The base is attached always at one position, but the tip can go in any direction. It can be like this, it can be like this, it can be like this, it can be like this. But this base is attached at one place only, and that is 2 centimeter below the ileocecal junction. The tip will decide the position, which can be variable. It can be towards the inguinal canal, it can be retrocecal, it can be pre-ileal, but the base is attached 2 centimeter below. But how to find this base intraoperatively? So, the surgeon has to follow the tinea, and all the 3 teneas are meeting at the base of appendix. So, this is very commonly asked question that at what point all the 3 teneas meet. So, in this image, if you will see, we are seeing from the posteromedial side of your colon, you can see that this is the attachment of the base of your appendix. And here you can appreciate that all the 3 teneas are converging. This is the one tinea which is converging, this is the another tinea which is converging, and this is the tinea converging. So, all the 3 teneas are converging at the base of appendix. That is why we are using the word that the base of appendix attachment is consistent, and all the 3 teneas of the large intestine converge at the base, and then they will spread out as you will go towards the ascending colon. So, the location of the rest of the appendix variable, which is depend upon the tip. The tip may be go in any part of your abdominal side, but in 80 to 95% people, the appendix is present in the retrocecal, that means behind the cecum. Now, how will you do the surface marking? Now, for the surface marking, you first know about the transtubercular plane. So, this blue color line is showing the transtubercular plane. Then you have the right side lateral plane, and you have the inguinal ligament. So, if I will join all the 3 parts, you are having a triangular area in the right iliac fossa just above the right half of inguinal ligament, and this part is having the cecum, which is related with the anterior abdominal wall. So, above you have transtubercular plane, below you have the inguinal ligament, and on the medially you have the right lateral plane. So, that is what you have to identify in the exam. Now, what is the blood supply? As I already told you initially that it develops from the midgut, and you know the midgut artery is superior mesenteric artery. So, basically the source of blood is superior mesenteric artery, and superior mesenteric artery will give the two branches. One is known as anterior cecal artery, another is the posterior cecal artery, and apart from that the appendicular artery is also contribute, which is a part of ileocolic artery. Now, what is the venous drainage? Now, you know that there is a superior mesenteric vein, and superior mesenteric vein joins the splenic vein to form the portal vein. So, it is again the part of portal system where the vein of your cecum will drain into the portal vein through the superior mesenteric vein. Now, what about the lymphatic drainage? Now, this is the question. You have the one-liner. What is the lymphatic drainage of cecum? The answer is pre-aortic group of lymph node. You have the lymph node which lies deep on the on the posterior wall of abdomen along with the aorta. They are known as pre-aortic lymph nodes. So, first the lymph will pass into the ileocolic group of lymph nodes, and from the ileocolic it will pass to the superior mesenteric, and from the superior mesenteric it will enter into the pre-aortic group of lymph node. Now, what is the nerve supply? Any visceral organ is having the autonomic nervous system. So, autonomic nervous system is having two parts, sympathetic and parasympathetic. Now, when you will have the parasympathetic supply, so dear students, we have seen that the foregut, if you will see the supply, you will realize that the foregut and the midgut, they are parasympathetic supply comes from vagus nerve, but the parasympathetic supply of hindgut comes from the segment S2, S3, S4. So, this is the important thing which you have to understand, that we are talking about the cecum which is coming from the part is midgut. That is why the parasympathetic supply comes from the vagus nerve. Suppose you have the question, what is the parasympathetic supply of descending colon? Then it is not vagus, then we are talking about the hindgut, then you have to move it to the sacral segment, second, third and fourth. What is the sympathetic supply? The sympathetic source is from the T11 to L1 spinal segment through the superior mesenteric plexus. Now, these are the two very simple clinical anatomy. First is abnormal position of cecum. Now, why the abnormal position of cecum occurs? It is all based on the embryology. So, because of the faulty rotation, if the gut tube rotates abnormally, then you may have the cecum in the left iliac fossa. If my intestine will rotate not on the right side but on the left side, so cecal bud will come on the left, then the cecum develops on the left. So, it is due to the abnormal or faulty rotation. It may be umbilical, it may be subhepatic, or it may comes into the right lumbar region. Sometimes the cecum may present in the pouch of Douglas. The second is inflammation. Now, inflammation of the cecum is known as cechitis or typhlitis. Then sometimes the cecum may involve in the intestinal tuberculosis. Intestinal tuberculosis is very important to understand that it is not only going to involve your small intestine, but sometimes the infection may set into the cecum, and that is the ileocecal tuberculosis. And sometimes the cecum may be the site of your malignancies. So, when you are seeing the applied anatomy is abnormal rotation, you have the inflammation and tuberculosis and malignancy. So, at the end of this lecture, now you know what is cecum. Second thing is, which is more important, what is the junction of the cecum and ascending colon. So answer is the opening of iliocecal junction. Apart from that, what are the internal features? What are the characteristic features of the large intestine? What is the nerve supply, blood supply, and applied anatomy of cecum? So this is all for today's class. Thank you.